And then you need an A to find an A, and you heard about MRA and CTA. The A we're looking for is aneurysm. The A to find an angiogram. There is no A in MRI. So you cannot just have MRI in your head. You have to have very specific sequences in mind. And then we're going to talk about the Horner protocol and how to image the orbit. So the prototype in the United States, of course, for optic neuritis, 20-year-old white female, acute unilateral loss of vision, right eye, central scotoma, pain with eye movement, RAPD, normal fundus. So my dad would say if it quacks like a duck and looks like a duck and flies like a duck, it's a duck. The problem is your duck here in Kuwait does not look the same as the duck that's in the publications for American and Canadian and European optic neuritis. And that's because you have all these expats and laborers from other countries, and so you have to know what optic neuritis looks like in Bangladesh. You have to know what optic neuritis looks like in India. You have to know what optic neuritis looks like here in the Middle East, and you have to know the European version of optic neuritis. So the imaging study that we're going to be looking at is called T1 post-contrast fat suppression orbit. So which one do you think that is? Is the T1A or is the T1B? B. Yeah, B. So we know that the vitreous and the CSF are very, very bright on T2. So when you see the bright signal in the globe and in the CSF, that's T2. So MR is weighted towards time constant number 1, T1, and weighted towards time constant number 2. T2 is the water study, so it shows water better. But T1 is our anatomy study, and the gadolinium enhances on T1. And normally the fat in the orbit is very bright, so we want to suppress that fat, and that suppression sequence is called fat sat. It's saturating out the fat signal so that we can see that this intraorbital optic nerve is demonstrating gadolinium enhancement. You see that where that arrow is? So that is what we're looking for, gadolinium enhancement, T1 post-contrast, MR, head, orbit, gadolinium, fat. And on T2, what we can see in optic neuritis is high signal. So the language of MR is signal intensity. So hyper-intense, hypo-intense, iso-intense, gadolinium post-contrast enhancement, T1, hyper-intensity. In CT, the language is density. Hyper-dense, iso-dense, hypo-dense. Because the only thing that matters in a CAT scan is density. X-rays go in, X-rays come out. The density of the tissue is what determines what comes out the other end. And the same for OCT. The language is reflectivity, hyper-reflective, hypo-reflective, iso-reflective. For echo and orbital ultrasound, hypoechoic, hyperechoic, and for fluorescein, hyperfluorescent, hypofluorescent. You're kind of getting the idea that whatever the imaging modality is, you have to put those words hyper, hypo, or iso next to it. So this is a prototypical MR, T2 hyperintensity, and post-contrast T1 hyperintensity optic neuritis. You can see that the contrast material in MR will appear anywhere there's no blood-brain barrier, like these extraocular muscles, or in any place where there's disruption of the blood-brain barrier, like in this optic neuritis. So everywhere else, there should be no contrast. The other thing you need to know is the thing we're looking for is multiple sclerosis in the prototype optic neuritis, but in your part of the world and in your Asian cohorts and in your brown people cohorts and Afro-Caribbean, African-American, and African patients, neuromyelitis optica, the antibody-mediated optic neuritis. So you need to know both the regular optic neuritis, MS, the one that's on all the books, the one that's on the test, and if you're getting tested in Canada, you have to know MS. But here in your part of the world, you have to know about the antibody-mediated ones. There are two antibodies. Neuromyelitis optica spectrum disorder antibody is called AQP4, aquaporin 4, NMO antibody, and MOG, myelin oligodendrocytic glycoprotein. So you need to know about both the MS, non-antibody optic neuritis, and the antibody optic neuritis. And this is T2, but it's flare. So just like we can suppress the signal with fat suppression on T1, this is a suppression sequence for fluid, CSF fluid called FLAIR, fluid attenuation inversion recovery, FLAIR. So FLAIR suppresses the bright signal in the CSF and allows us to see pathologic white matter. So that is what you're looking for in MS, multiple lesions separated in space and time. And after gadolinium, some of these lesions are enhancing. That demonstrates that they're different times. The enhancement is the active lesion. So we've got different times and different spaces, multiple sclerosis, dissemination in time and space. If you don't give the contrast material, we can't see anything. So the most common reason why an ophthalmologist would miss an optic nerve sheath meningioma is you image the head instead of the orbit, you didn't give the gadolinium, or you didn't suppress the fat. So we need to have MR, head, orbit, gadolinium, fat set. MR, head, orbit, gadolinium, fat set. That's what's required for any optic neuropathy. Because even if it looks like optic neuritis, you don't know it's optic neuritis until you scan the person and you examine it. So if you don't give the contrast, you can't see my house at night. This is North Korea at night. So you can see that South Korea looks like an island when really it's a peninsula. And the only thing that's lighting up at night in North Korea is Kim Jong-un's house in Pyongyang. The rest of North Korea at night is dark. So if you want to know the difference between the north and the south, you just look at this picture. And that's the same thing that happens if you don't give the contrast material. It'll be North Korea at night. Okay? So you have to give the contrast to see the contrast enhancement. So this is normal fat. You see how bright the fat is? So is this T1 or T2? Fat? This is T1. But we don't want to see this fat. We want this fat to be turned off. So we want the fat to be suppressed. That sequence is called fat suppression. So we have two inversion recovery sequences to turn off normal signal. On T1, that's called STIR, short taw inversion recovery. So an inversion recovery sequence is, the sequence is going like this, and we're just going to cancel it out like this. It's the same principle that you have for Bose noise cancellation. So they're making noise in that headphone to cancel out noise. You get nothing. And for flare, that's also an inversion recovery sequence. Fluid attenuation inversion recovery, that's for CSF, that's T2. So we have inversion recovery suppression sequences for T1, that's fat suppression, also known as fat sat, and we have T2, flare. So which one do we need for this orbital MR if we give the contrast? T1 fat sat, that's right, T1 fat sat. So this is no fat suppression. The normal fat in the head, you see the fat in your scalp here, and the fat in the orbit. This is no fat suppression. But fat is our friend. So we like to see fat, not here, but in the orbit. If you give the contrast material now, can you tell if that nerve is enhancing?
No.
Why not? The fat. So white stuff on white stuff is white stuff. So you cannot see the nerve is enhancing because you didn't suppress the fat. So you can see the contrast material in the nose because there's no blood-brain barrier there. And so if you don't use fat suppression, you will miss the tumor, sheath meningioma. You will miss optic neuritis. You will miss MOG, sheath enhancement, because it's just lost in the fat. And this MR will be read as normal. It should say, hey, if you're looking for something in the orbit, like optic neuritis, you should order fat suppression. It doesn't say any of that. It just says no acute intracranial abnormality. It should say you have ordered the wrong test for the thing you want us to look at. But radiology, they don't tell us this. They just say normal, non-fat suppressed MR head.
Why do they suppress fat by default?
Why don't they just do it by default?
Yeah,
So it takes time. And also you have to give the suppression sequence, the inversion recovery sequence. So time and money. So it's time basically, okay? And when you're doing non-fat related things, you don't need the fat suppression. So for your head, you don't need fat suppression because there's no fat in your head. So for the typical MR of the head, they don't care about fat suppression. It's only when it's in the orbit that the fat suppression matters to us. So us as ophthalmology, we need to know that there's this special sequence, fat suppression, for the orbit. Because they don't care about the head, that's why they don't do it. So you have to suppress it. Polar bear in a snowstorm. White stuff on white stuff is white stuff. So you must suppress the normal white stuff. And what's the normal suppression sequence? What was it? Fat suppression. Yeah, fat suppression. The other thing you should know is if you have a cellular lesion, we need to have both head and orbit, even though you know the lesion is in the cella, because some of the lesions, like meningioma, go into the orbit. So any lesion that is producing a cellular field, which you remember was the bitemporal hemianopsia, there's some things on this list where we need to know, is it going into the orbit? And the reason that's important is if it's meningioma and if it's going into the orbit, you can't take it out. That needs to be radiated. So the typical scenario is you know that the person has a cellular lesion, but you didn't order the orbit. They see that it's a meningioma, and then they take out the meningioma, the person's vision doesn't get any better. So then you repeat the scan, MR, head, orbit, gadolinium, fat set, and the reason they didn't get any better is the lesion is in the orbit, and they couldn't get that. So all these other ones, the cell sequence alone is fine. So any bitemporal hemianopsia, but also optic neuropathy could be a chiasmal lesion. You remember that? The number 1 field defect. The number 2, junctional scotoma, 2 types. Ipsilateral vision loss plus superior temporal field defect in the fellow eye from the crossing nasal fiber. The junctional scotoma of trochlear, the monocular one-eye hemianoptic field defect, the bitemporal hemianopsia, and if you're in the tract, you remember the tract? That causes contralateral homonymous hemianopsia. There are 2 extra findings in the tract. Remember what those 2 findings were? The bow tie atrophy in the eye with the temporal field defect, and the pupil exam is going to show RAPD. So RAPD plus homonymous hemianopsia plus band or bow tie atrophy, that's tract. And if it's tract, you got to worry about one of these big 5 lesions. The top 5 in adults: pituitary adenoma, craniopharyngioma, suprasellar internal carotid artery aneurysm, meningioma, and disc germinoma. In a kid, you would put on glioma, and you would take away the aneurysm and meningioma. Everything else is the same. And if it's acute and painful, there are 2 bad things that could be. Acute painful bitemporal hemianopsia, the one that kills you, apoplexy, but the other one that kills you is the aneurysm. So if it's acute and painful bitemporal, you have to have that A, the MRA or CTA, to look for that A, aneurysm. So you heard about using the angiogram for carotid dissection, for aneurysm, but also you need to know about this acute painful bitemporal hemianopsia. So the key and differentiating words are acute and painful. Acute and painful plus any neuroophthalmic sign is bad. Acute, painful, anisocoria, that's bad. If it's the big pupil and the big ptosis, which one was that? Third nerve palsy. And what's the dangerous thing with acute, painful third nerve palsy? That's the aneurysm one. That needs the CT, CTA followed by MRI, MRA. And how about the small pupil and the small ptosis? That's the Horner's. That needs a Horner protocol, which we're going to talk about, all the way down to thoracic T2 in the chest. So you need to add an angiogram if you think it's arterial aneurysm, arterial dissection, arteriovenous fistula. Any A needs an A. And how about if the patient is pregnant or postpartum? What's the name of that when they get this bitemporal hemianopsia? Remember what the name of that syndrome is? Sheehan syndrome. That's on the test a lot. So you need to know acute, painful, bitemporal in pregnant lady, Sheehan syndrome. But now that you know the anatomy of the chiasm, you know that it can still be acute, painful optic neuropathy and be apoplexy. You know it can be acute, painful junctional scotoma or junctional scotoma trochlear and be apoplexy. And you now know it can be acute, painful homonymous hemianopsia and still be apoplexy. All of those are apoplexy, even though the book only has 1 in there, bitemporal hemianopsia. The reason the book only has 1 is the chiasm. This is the Greek letter chi. It means cross. So if the tumor is right below, like that coffee is the tumor, it hits the body of the chiasm, it produces what field defect? Bitemporal. If, however, the chiasm is post-fixed like this, it'll hit the junction or only 1 optic nerve. And if the chiasm is prefixed like this, what will it hit? The tract. So you should now know that a pregnant or postpartum lady with optic neuropathy, junctional scotoma of trochlear, bitemporal hemianopsia, or homonymous hemianopsia, all of those are Sheehan until proven otherwise. So if you just add in one word into that acute painful vision loss, it's apoplexy. That one word, pregnant or postpartum. If you add that in there, do not fool around with that. So there's some conditions we cannot let the sun set on acute painful pregnant lady or acute painful postpartum lady. Do not let the sun set. As soon as that lady says, I have blurry vision, you have to do a field, and no matter what it shows, if they have optic neuropathy, chiasmopathy, or tract, you have to image that tonight. Do not let that person go home. And this is the imaging of apoplexy. It's like this big ball of fire right underneath your chiasm. So yesterday, you learned this, number one, optic neuropathy. But in every patient who has optic neuropathy, you have to test the good eye, even if it's 20/20. And what are you looking for? That superior temporal field defect in the fellow eye. What's the name of this field defect? It's called the junctional scotoma because it's at the junction of the optic nerve and the chiasm. And if you're just hitting this crossing nasal fiber or hitting this uncrossed temporal fiber, it will produce a monocular and hemianopic field defect. Only one eye has a temporal field defect. That's also a junctional lesion. What's the name of that one? The trochlear, the junctional scotoma of trochlear. That's usually not listed in the book versions of the field. The bitemporal hemianopsia, and you remember that number 4 is the posterior crossing macular fiber, the bitemporal paracentral, and the tract. And you remember the two things that are associated with the tract? One's a pupil finding, RAPD, and the other is an optic nerve finding, band or bow tie atrophy. You need to just know all of that code. These are all chiasmal syndromes, all of them. They're all chiasm. It's just a matter of the anterior chiasm, the junction of the chiasm body, posterior chiasm, or the tract. They're all chiasm. So if you just remember this letter X, you know that it can be the front part of the X, the junction of the X, the back part of the X. They're all X. All of them are chiasm. So if you look at a mass lesion, in this case it's a pituitary lesion, and it's pressing on these crossing fibers there, that is what makes the junctional scotoma. One eye has an optic neuropathy, and the other eye has the superior temporal field defect. Now, that thing anatomically has a name. Who knows what the name of that is? The Wilbron knee, but it doesn't matter whether that actually exists or not. There's some controversy as to whether this Wilbron knee actually exists or not, but it really doesn't matter. So if you take this thing and you just push it back here, it still localizes right there. It doesn't matter whether the Wilbron's knee actually exists anatomically or not. In the clinic, it doesn't matter. So you can argue about whether the knee anatomically exists or not, but it makes no difference. You see that field defect, that is junctional. And so it's super dangerous because this person's going to be complaining about central loss here and say they're count fingers, and they have an RAPD, and you're not going to want to test the other eye. In fact, when you try to test the other eye, they're going to say, hey, doc, why are you testing that eye? This is the bad eye. But what if you find that? That's almost always a compressive lesion. So if we see the junctional scotoma, that is pituitary apoplexy until proven otherwise in the acute setting. In the chronic setting, it's any one of those on the big 5 list. You need to know about this version of it, which is a monocular temporal hemianopic field defect. What's the name of this thing? The one eye field defect only. No, there's no, this is only one eye. It's the junctional scotoma trochlear. And that thing has this special kind of atrophy also. What's the name of that atrophy? Band atrophy. So if you have band atrophy in only one eye and a temporal hemianopic field defect, temporal field, nasal fiber is the band. This is also a tumor. And if it's acute and painful, you have to have that A, the angiogram. What are you looking for? Aneurysm. So in the optic neuritis treatment trial, U.S. ophthalmologists were asked to recruit patients with optic neuritis. They all had the same story, 20-year-old, white female, acute, painful, loss of vision, RAPD, normal fundus. 2 of the cases weren't optic neuritis. One was pituitary apoplexy at the junction, and the other one was ophthalmic artery aneurysm. You can see how those both would be acute and painful. So you have to ask the patient a question, how bad your pain? So the pain in optic neuritis is like a 2 on the 10 scale. It's just pain when they move their eye. What if it's 10 on the 10 scale pain? That's the aneurysm. That's the apoplexy one. That's the one you need the A on. Okay. So 22-year-old female, worst headache of her life, bilateral vision loss. She has that field defect. Where's the lesion? Body of the chiasm. What's the diagnosis? This is apoplexy. How come the vision is 20/20? Because this half of your macula can still see 20/20. It doesn't matter that this side is missing. That side's still 20/20. How come there's no RAPD? It's symmetric loss, bilateral. No R, no RAPD. It's bilateral vision loss. And how come the fundus is normal? It just happened today. It's apoplexy. There's no time for that to cause optic atrophy. Yes? Now, this person shows up in comprehensive or plastics or retina. What will be the retina exam? Normal. They're going to do an OCT of the macula. What will it show? Nothing. They're going to do an OCT of the nerve. What's it going to show? Nothing. And because of that headache, they're going to say, well, you need to go see neurology or go to your medical doctor. When really, what should they have done? So any patient with blurry vision needs to have a field if you don't have an explanation. The way that ophthalmologists blow this case right here is they find something, epiretinal membrane, or keratoconus, or mild lens opacity, and then they just say, well, that has nothing to do with your headache. Go to neurology. If you let this person leave and it's Friday, they die on Saturday. You kind of need your pituitary, yes? So if you look at the number of patients who have pituitary apoplexy, who are adrenal insufficiency, you need this cortisol. If you don't have the cortisol on Friday, 4:45 p.m., when you get up in the morning at 4:45 a.m., expecting that cortisol boost, it won't come and you die. That one day made the difference. Do you understand how dangerous this case is? Apoplexy, don't fool around with it. You can see the percentages of the people who have deficiencies of their hormones. And it can be precipitated by things that are not related. So their blood pressure might be high, and you might say, well, your blood pressure is high. That's why you have the headache. But that's what caused the bleeding, the hypertension. It can be after surgery of any kind. So if you're called to the hospital and they say, hey, this guy has blurry vision after having cardiac surgery, but you're going to find the dry eye or like some unrelated thing. Well, why do they have the worst headache of their life? They need to be imaged. And the pregnancy one, that's the one that's in the book. Isn't that the one you learned? What's the name of that thing? But look at all these other ones that don't have no name. So the ones that have no name are the ones that are dangerous. Of course, if I say it's acute, painful, bitemporal after pregnancy, everybody knows that she-hands. Everybody. But how about all those other ones? So this is what you're looking for, an intracellular mass with a supracellular extension. It's like a snowman because it started as a snowball in the cella. It got out of the diaphragma cella and then became a snowman. Do you see the snowman? Yes. You don't have no snow in Kuwait, but you know what a snowman is, yeah? Snowman. Snowman bad. Pituitary adrenal. So any patient with acute, painful, bitemporal hemianopsia is danger. Danger. And if you ignore it, it will end in tears. We cannot have end in tears be the ending of this story. It must end in tears of joy, not tears of pain or death or suffering. It's your job to identify this person as pituitary, as an apoplexy. And if they go to surgery, there's a 90% chance they're going to get their vision back. 90%. And if we get the cortisol on board before the adrenal insufficiency, they live. they go home on hospital day 4 because transsphenoidal surgery is not as big a surgery as a craniotomy. Go home hospital day 4. Yes? The average ophthalmologist sees 1 pituitary apoplexy every 10 years. Are you meeting your quota? You, as a general ophthalmologist, should see a pituitary adenoma every single year. The average ophthalmologist sees 1 pituitary adenoma every single year. You say, look, I haven't seen any. You sent some adenomas out. Okay? Because even orthopedic surgery knows that bitemporal hemianopsia is bad. Okay? The one you don't know is the one that looks like optic neuritis, the junctional scotoma, traqueare, and the homonymous hemianopsia. Those are the ones that ortho can't figure out. Okay? You got to be better than ortho. And we can do the macular ganglion cell layer on patients who have borderline fields. So if I show this field A to my residents, they won't get it. But do you see the bitemporal that's inside that field? Do you see it up there? See how tiny that thing is? But when we do the macular ganglion cell layer, half is missing. So no retinal disease can do this. Retinal disease cannot do half of a macular ganglion cell. So the ganglion cell loss is seen way before the field defect. So you should be using macular ganglion cell analysis when you're doing your OCT. You guys have this, right? The problem is you're only doing OCT neurofiber layer. Isn't that what you're doing? And then when you're doing the macula, all you care about is what retina cares about, which is epiretinal membrane, macular edema, AMD. That's all they care about. But we have to have the ganglion cell. Okay?
Would this happen acutely though?
Nope. So in the acute setting, if it's normal, it doesn't protect you. But if it's abnormal, for sure they have something bad. Okay. So of course it's the chiasmal tumor that caused this macular ganglion cell, and in the retina, the nasal fiber does the temporal field. So OCT, super great, but you have to do the macular ganglion cell layer, not just the RNFL, the retinal nerve fiber. What's the name of A? A monocular temporal hemianoptic field defect? The junctional scotoma of troquear. That eye has band atrophy. Yes? There'll also be an RAPD, all on the right. How about B? What's the name of that field defect? That's the left homonymous hemianopsia. Now, that could be a stroke, but I can make it into apoplexy by adding that pupil finding in. What's the pupil finding? RAPD, because stroke, very uncommon to go into track. And the band atrophy in B, which eye will have the band atrophy? The right or the left in a left homonymous hemianopsia, if it's a track? The left. So the left eye will have the band in B. How about C? Could someone ask me this? The altitudinal field defect. Remember that yesterday? Could that still be the apoplexy? Yes. But the most common cause of that field right there is glaucoma. But you better have a cupping. What if you look in the back of the eye? There's nothing there. You got a big problem now. What if they're 80 and they have loss of vision and they have a RAPD and a swollen disc? Well, that's AION. So we have to see either cupping or we have to see disc edema. What if you see nothing? That's the apoplexy or optic neuritis. How about D? Where's that lesion? See, it's bitemporal, but it's paracentral. See that there? Is that chiasmal? Yes, that's the posterior chiasm, number 4, the crossing macular fiber. That's also bitemporal. Yes? How about E? That's also homonymous. How about F? That one's orthopedic knows that one. Yes? So, of course, ortho knows F. But how about all these other ones? Ortho doesn't need to know a damn thing about the other ones. Yes? So you have to be at least better than orthopedic surgery for these fields. So you need to know that the pituitary gland lives inside this saddle, a Turkish saddle. What's the name of this thing? Sella Turcica. The Turks. Somebody inside my saddle here. See the mask? So you need to be able to see the saddle, the Turkish saddle, Sella Turcica, and there better not be anybody in that saddle. So you're gonna look in the saddle, and you're looking for a snowman riding in the Turkish saddle, yeah? Snowman. You want to know snowman. So you need to know the coronal version of it as well. So the pituitary gland, the stalk, the chiasm, floor of third ventricle. And sometimes these people have a special type of nystagmus. What was their nystagmus? The localizing form. Seesaw. Remember that? So you need to know there's got to be some space, 10 millimeters of space between the top of the chiasm and the bottom of the cell, top of the cell. 10 millimeters. So any tumor that is producing a bitemporal hemianopsia or an arcuate or homonymous has to be snowman. It cannot just be snowball. What if it's just snowball in the cella? That's not the cause of their vision loss. So if the MR comes back and says there's a pituitary microadenoma, is that the cause of the person's vision loss? Nope. So please don't just write down pituitary adenoma in the chart. You have to know whether it's snowball or snowman in that cella. What if it's snowball? That's not the cause of the vision loss. Go find the real cause. What if it's snowball plus snowman? That one is the cause. And that one is called macroadenoma. So it's macro when it goes snowman. If it's just snowball, micro. Micro cannot press on chiasm. So you can blow it two ways as an ophthalmologist. One is you don't know the imaging, and the second is you know the imaging, but you made a mistake on the clinical radiologic correlation. So clinical radiologic correlation is required. You must correlate whatever they saw to whatever we see. And pituitary microadenoma cannot do anything to you. Nothing. That goes to endocrine. You remember what the name of that field defect is when it's monocular and heminopic? That's troquere. However, in this particular troquere, it's a nasal heminopic. You see that? It's only one. And will this eye have the band atrophy if it's the nasal field? Nope. It's only when it's the temporal monocular hemianopsia that it makes the band atrophy. This just makes regular optic atrophy. So you need to know both the junctional scotoma, ipsilateral optic neuropathy, plus contralateral temporal field defect, and the bitemporal are both chiasmal. You need to know that this homonymous hemianopsia. Now this is pi in the, and if you don't have an RAPD and you don't have optic atrophy, that's in your temporal lobe, and the name of that fiber, the loop. Look how much you learned yesterday. Yes? So the Meyer loop, and which side is this lesion on? If this is a right homonymous quadrantenopsia pie in the sky? Left. So this is a left Meyer's loop, but if I just add in the pupil or the band atrophy, that's in the tract. And that converts it from being a stroke into being a tumor. Could this still be occipital? It could be. And what you're looking for is congruity. It's the exact same in each eye. So you actually don't know whether this is temporal or occipital. But what I do know is if I have an RAPD and band atrophy, it's this tumor. You see how the snowball can be so big it goes outside. Giant snowball. However, what we're looking for is snowman. Snowman. You see snowman? Houston, Texas is like Kuwait. We don't hardly have any snow. So our Museum of Fine Arts has to make snow with a snow machine so that children in Houston know what snow is. Otherwise, they will never have seen snow in their whole lives. And they go out and they make a snowman with the snow that was made with the machine. Their snowman is this big because it melts right away. So my kids, they made a snowman when they had never seen snow in Houston. All right. So most of the time, the snowman just goes straight up. And if he goes straight up, he hits body of chiasm and produces bitemporal hemianopsia. In bitemporal hemianopsia from snowman, which eye has the band? Bitemporal.
No one.
No, both eyes have the band. Yes, because both have the temporal field defect, which is the nasal fiber. So both eyes have the band in bitemporal versus the tract lesion, only the eye with the temporal field in the homonymous hemianopsia has the band. You understand the difference? But either way, band is bad. If it's band in one eye only, that's the junctional scotoma of, that's bad. If it's bitemporal, which eye has the band? That's bad. If it's homonymous, which eye has the band? The eye with the temporal or the nasal field loss? That's bad. So if we see band atrophy, it's bad. So you need to look for this band atrophy in every single patient because what residents write in the chart is temporal pallor. First of all, that's not temporal, that's nasal. And look at this snowman. What's happening to my snowman? Bending to the right. So he got a banana like this. He's supposed to grow up like this, yes? But he decided he's just going to go like this. And if he just goes like this, he'll only hit the junction of the optic nerve and chiasm on that side. So I told you about the chiasm, prefixed, postfixed, prefixed. But there's also the tumor decided he just wants a banana to the right. So if he just wants the banana to the right, a banana to the left, that's what produces the junctional scotoma of Traquair or the junctional scotoma. It just decides, I don't know why, it went to the right. You see that? The tumor went to the right there. Why did he do that? Yes? So, if it just goes straight upstairs, orthopedic surgery by temporal hemianopsia. Which eye has the band? Both. You need to be able to tell the difference between a snowball and a dirty snowball. This is craniopharyngioma. So it has both a cystic component, you see the cystic component, and the solid component. And most of the lesion is suprasellar. So even though it's a snowman, it's like a snowman on his head. His head is bigger than his body. And that's because the lesion started more suprasellar. So if we see this dirty snowball thing, this is craniopharyngioma. And it changes the approach. So pituitary adenoma, almost always transsphenoidal. But if it's this giant thing, you have to do craniotomy. So craniopharyngioma is both cranio and pharynx. It's the pharynx part that is making the cyst. It's trying to make a spitball. So it's got a solid component, and then it's got this cystic component. You see that cystic component? Now, of course, cystic adenoma can do this, but it's really important for us to tell neurosurgery that the lesion looks more like craniopharyngioma to us. So how would we say to them that it looks more like craniopharyngioma? If it's pituitary adenoma, if it's bitemporal, is the field defect going to be denser superiorly or inferiorly if the compression is from snowman from below? But what if the field defect is bitemporal and it's denser inferiorly? That means you should be thinking meningioma or craniopharyngioma. So that one piece of information is enough to help neurosurgery understand that they need to do a CAT scan to look for calcification for craniopharyngioma, which might change the surgical approach. You understand how important it is for us to examine this person in advance and tell them whatever's pressing is pressing from above or pressing from below. That is completely made by looking at that field. So the reason you have cranio and pharynx in your head is the embryologic origin of the craniopharyngioma. This is the normal embryology of the pituitary gland. The anterior pituitary gland has a different embryologic origin than the posterior. The posterior, the neurohypophysis, comes from neuroectoderm. The anterior comes from surface ectoderm. So it's like a stalactite and a stalagmite, one coming from above and one coming from below, and when they meet, that's what makes the pituitary gland. This cleft right here is a potential space. called the Rathke's cleft. A cyst can form right in that location called a Rathke's cleft cyst. The outpouching from the surface ectoderm, trying to make the adenohypophysis, the anterior pituitary gland, is called the Rathke's pouch. If you have a piece of tissue stuck in there, it'll make a tumor that's trying to make pharynx and a spitball. That is called craniopharyngioma. It is both cranio, neuroectoderm, and pharynx, surface ectoderm, the remnant of the Rathke's pouch, stuck in the Rathke's cleft, making a suprasellar mass lesion that the person has years later. So you need to know that the primitive forebrain, the diencephalon, is going to be making the Rathke's pouch from surface ectoderm and the neuroectoderm, and in between those two is the Rathke's cleft. And so you need to know a little bit about the embryology you learned as a medical student, because today you need it. The Rathke's cleft cyst, craniopharyngium. All right, what are we going to tell neurosurgery here? When they have a bitemporal hemianopsia, it's denser inferiorly. So what should we tell them? We think the compression is from, and that we think this is more likely to be, and that maybe you should consider doing a craniotomy instead of a transphenoidal. Because what will happen if they do transphenoidal and the tumor is completely above the pituitary? You'll have to go right through the normal pituitary, and now you made someone panhypopit that didn't need to be. When we could have done a craniotomy and taken the whole thing out from the top. But what if you don't tell them anything? They might think it's cystic pituitary adenoma. Transphenoidal. They might not do the CAT scan. The CAT scan is to look for calcification that's seen in craniopharyngioma, but is super rare in pituitary adenoma. So sometimes we need both a CT and an MR. Okay? So all these cystic things need CAT scan to look for calcification. It will change the surgical course. Do you understand how you're supposed to be a team player here? There is no I in team, but there is eye exam in team. We're part of a team. Doctor first, ophthalmologist second, retina doctor third. In that order. Program director fourth. Yeah.
We usually get Goldman's in the exam, but it's difficult to interpret them. So how can you correlate this visual field defect with the Goldman on top?
So in the clinic, we have 24 and Humphrey automated perimeters 24 degrees. That means it's only measuring right there.
Mm-hmm.
So in the Goldman, you can see the part that's missing is respecting the vertical meridian. That's where that line is. So that quadrantenopsia is this thing inserted right there.
Oh, okay.
Do you understand how to read this thing now? So this automated perimetry, it's black. It's bad. But in Goldman, they just leave it blank. That's why it's so hard to interpret. So in a Goldman, you're making an isopter, a ring of similar size stimuli. So it's supposed to be ring on top of ring on top of ring. What if the ring has a piece missing? Then that's what that's correlating to. What if it's a big ball of fire with heterogeneous signal, but it's like a whirling round thing? What are you worried about with this whirling round thing? This is the aneurysm. So if it's a black and white ball, the dark part is flow void. So you remember in MR, MR is magnetic resonance imaging. We're imaging magnetic field of proton. But in fast-moving protons, they're just running through the machine. So in arterial blood, so it never gets a chance to align in the magnetic field. So fast-flowing blood makes a void in the signal created by the high flow. This thing we call the flow void. So all arterial blood shows no signal on MR. It's just black. So when we see this very, very black thing, and it's very, very round, and it has white stuff inside of it, this is a black and white ball of fire. This is the aneurysm, okay? This one needs that angiogram, okay? Do not fool around with this, okay? This needs to go to neurosurgery like right now, because that big ball of fire could rupture. Pituitary adenoma, that could make apoplexy, but probably not. Craniopharyngioma, nothing's going to happen to that person. You got all the time in the world. But this thing, it's time limited, okay? You don't make this diagnosis, they die. They just die. Half the people die at the scene, never make it to the hospital. And then you've got this meningioma. So meningioma, homogeneous enhancement, because everything inside of a meningioma is the exact same cell type. It's not like pituitary adenoma. It's not like craniopharyngioma. It's not like the aneurysm, which has heterogeneous signal intensity. And it has this dural tail. You see this tail? So dural tail, homogeneous enhancement, and it looks like a snail. You see my little snail there? So you need to be able to tell the difference between meningioma, pituitary adenoma, craniopharyngioma, because the surgical approach is different. And one of these three needs the orbit also. Which one needs the orbit? The meningioma. Because if that snail tail, the dural tail, is going through the orbital apex, they won't get their vision back. And then you'll be wondering why they had a craniotomy and they didn't get better. Because you didn't recognize the orbital part. The pituitary adenoma and the craniopharyngioma are extremely unlikely to go into the orbit. So that one, you can do it, but you don't really need it, okay? You need it for this one. Because the residual in the orbit needs to be radiated. So sheath meningioma, regardless of whether it's primary, it's only in the orbit, or secondary, it came from intracranial, radiation therapy is our primary treatment. You cannot take it off the sheath, they'll just go away. And then you've got this suprasellar dysgerminoma. It looks very like cloudy. Do you see how it's like cloudy looking? So it's like a snowball that's kind of partially melted because it's dirty and melting. So this is suprasellar dysgerminoma. The critical feature is involvement of the stalk. You see this infundibulum here? So it's going up the stalk. So infiltrative neoplasm, like dysgerminoma, can crawl up your stalk. The pituitary adenoma, the cranio, and the meningioma don't cause infiltration of the stalk. So, what if you don't know? You have to go talk to radiology. Okay? You have to go talk. Because if it's this one, this can be radiated. Bottom line, all of these are chi. Chiasm. Anterior chiasm, junction of the chiasm, body of the chiasm, posterior chiasm, optic tract. They're all chi. F is for orthopedic surgery. All the rest are for you. You understand what you're supposed to be doing on the test and in the clinic and with real people. So you should know that a suprasellar mass can produce a bitemporal hemianopsia. That's the orthopedic surgery version, the book version, the medical school version of chiasmal lesion. That's 80% of the time it's that. 5% of the time it's the tract. And 15% of the time it's optic neuropathy, junctional scotoma, or junctional scotoma of Triquetri. And that means if you see 10 cases, which you will see 10 cases of suprasellar in your career, 2 of them are not going to be the orthopedic surgery version. You need to know any unexplained optic neuropathy needs an imaging study, even if it's altitudinal field defect. You must image. We were just talking about this in the car. I get invited every year to speak in other specialties subday. The talks are always the same. This year I'll be speaking in Orlando in retina. Their question, when should we scan retinal disease? Answer, a special kind of retinal disease called not the retina. And it's the same topic in glaucoma. When should we scan glaucoma? Special kind of glaucoma called not glaucoma. When should we scan pediatric childhood strabismus? Special kind of childhood strabismus called not childhood strabismus. When should we scan oculoplastic ptosis? Special kind of oculoplastic ptosis called neuro. I've literally spoken in every single subject with the exact same topic. When should you scan, insert whatever they are? When it's not you, that's when you should scan it. And that's why even retina docs need to know about neuro. Because a general ophthalmologist confronted with unexplained vision loss after cataract extraction, the first person they're going to call is not neuro. First of all, good luck trying to get neuro to come see that. 6 months, maybe never. But retina will see anything at 11 o'clock at night. But then they get there and they look at the OCT and it's normal. Now they have to look at the nerve, but not just with the nerve fiber layer, and not just with their eyes, macular ganglion. You understand? They have to swing that light and look for something they never look for. Why? All their patients are already dilated. Yes? So, patient was already dilated. Just bring them back the next day. That's 8:30 in the morning before the clinic starts. Just swing the light. Otherwise, it'll be come back in 3 months. We'll do a field and we'll see what's going on with you then. Don't do that. Swing that light. Even if you didn't swing it the first time, swing it the second time. It's your job. You need to know about the two junctional scotomas. The junctional scotoma, ipsilateral optic neuropathy plus superior temporal field defect in the fellow eye from the Wilbrand's knee, regardless of whether that thing exists or not. And the monocular hemianoptic field defect, what's the name of that thing? Junctional scotoma square. And you need to know about the optic tract, RAPD band atrophy. And the top 5, the snowman. Which one's the snowman? And if it's a little snowman, that's not the cause of the vision problem. That is micro snowman, microadenoma. It has to be big snowman, macroadenoma. You cannot say pituitary microadenoma is causing anything in our clinic. It cannot be that. Don't write pituitary adenoma. You have to write pituitary micro or pituitary macro. Macro is us. Micro, retina. Okay. The dirty snowball from the combination of the neuroectoderm and the surface ectoderm. A piece of brain, cranio, and pharynx. Spitball in your head. That one's craniopharyngioma. It makes a bitemporal hemianopsia that's denser inferiorly. Black and white flow void with high flow and turbulent flow inside of it. And that one needs an A to find an A. You have to have some kind of angiogram here. CT, CTA, MRI, MRA. And if it's the snail tail, and if it's the snail tail one, you have to do head and with fat sat and gadolinium, because if it's in the orbit, got to radiate that residual. And if it's a young male with an intrinsic lesion that's extending into the stalk, that's dysterminal. That one can be radiated. All right, this is a 40-year-old white female with an acute, painful pupil-involved third, and that's the rule of the pupil. The rule of the pupil. Pupil-involved third is an aneurysm of the posterior communicating artery until proven otherwise. Yes? That is what they teach you, the rule of the pupil. But in the United States, we are imaging all third nerve palsy regardless of pupil. Is that what you're doing here?
Yes.
So it doesn't matter if it's partial palsy, partial pupil, partial ptosis, partial ophthalmoplegia, complete ophthalmoplegia. Everybody gets the same imaging study. And the imaging study of choice is CT, non-contrast, followed by contrast CTA. And if it's negative, MRI, MRA. Okay. So you need CT and MR for aneurysm. But really, third nerve palsy in general, doesn't matter what it's doing. Even though the rule of the pupil is still true. If it's pupil involved, that's the aneurysm. But if it's not pupil involved, it could still be the aneurysm. 50-year-old white female, acute, painful, little pupil, little ptosis. Is that good or bad? What's the name of that syndrome? So an acute, painful Horner syndrome, you're going to be looking for dilation lag. It occurred after car accident. The reason we are late today, your traffic sucks. Like yesterday, I said, oh, I got an hour to get back to the hotel. I'll be done at 2. I'll have a meeting at 3. Guess what time I got back to the hotel? 3:02. And the guy was driving like crazy. The driver that drove, he was like, your traffic, man. I thought Houston traffic. All right, what we're looking for? Flow void. You see the flow void, this little round black thing? That's because of the fast-moving blood in the artery. But this is slow flow. Why is it slow flow? It's dissected into a false lumen. So the fast flow, the round black thing, is the normal carotid. Surrounding it is a crescent of hyperintense signal intensity. That's the dissected blood. Do you see the crescent moon? And where is this? In their head or in their neck? And that means if you see a Horner's and you image the head, you did the wrong scan. How far are we supposed to go down? T2 in the chest. So the Horner protocol, you need to go make a Horner protocol with your radiologist, okay? Hypothalamus, MR head, all the way down to thoracic T2 in the chest. Because the dissection, this is the flow void. You see the black pipe? Fast moving blood, but this is slow flow. And the slow flow can lead to no flow. And if you get no flow, you'll stroke. So a quarter of these people are going to stroke in the next 24 hours. Another quarter in the next week. But if we give them an aspirin a day, just say it. Aspirin. Aspirin. This, the literal treatment of this. Aspirin a day. So the name of that thing is called the crescent sign. It's an acute, painful Horner syndrome after car accident. You need to do a Horner protocol, MRI, head and orbit all the way down to T2 in the chest. And what's the drop that we use? Aproquinidine. You also need to know about cocaine and hydroxyamphetamine, even though there's no cocaine in Kuwait. Right. All right, 60-year-old in diabetic ketoacidosis, acute painful ophthalmoplegia, proptosis, RAPD. That's the fungus. This one needs CAT scan, okay? CAT scan, better for bone, better for sinuses. What you're looking for is sinus opacification. And now, look, it's in the orbit, big muscle. What's the name of this? Mucor. Mucor. But on MR, fungus, black. Why? There's no water. So remember I told you MRT2 is the water study? There's no water in dried out fungal hyphae. They just look black. And this side is black. See, black? Because air is in there. But this side is black, but it's not air. It's fungus. So your radiologist will not be able to tell the difference between the hypointense signal of air and the hypointense signal of fungus if you only order this MR. You understand how dangerous this is. And so they're going to read this as pansinusitis, there's orbital infiltration, acute painful, rule out orbital inflammatory pseudotumor, Tolosa-Hunt syndrome, a whole bunch of crazy things. And you're going to be tempted to give what?
Steroids.
What will happen if you give steroids to fungus?
It gets worse.
You kill them. So steroids, no go for fungus. If you give fungus steroid, you'll get fungus among us. Do not give corticosteroid to this. So diabetes, DKA, CT scan, acute painful ophthalmoplegia, proptosis. When should you do the Hertel exophthalmometer? In patients who have acute painful proptosis, ophthalmoplegia. You should be doing it on people that don't look bulgy-eyed to you. That's why you have a machine. But when does my resident want to do the Hertel? Hey, Dr. Lee, this guy's Hertel, 32. I'm like, fantastic, but you can tell he's 32. His eyes bulging. So who do we need the Hertel on? 22. You understand what I've said? The one you need the Hertel exophthalmometer on is the one you don't know is proptotic. The person that's 32, you already know they're proptotic. The person you need the Hertel for is the 2 millimeter difference that only the machine can find. So you should be doing a Hertel exophthalmometer on every ophthalmoplegia that's acute, because what you're looking for is proptosis that the machine can see, but you cannot. If it's 32, go ahead and do the Hertel, but I already know that person's proptotic. You understand how dangerous it is to only do the Hertel exophthalmometer on people who don't need it. You have to do it on everybody, so you can practice. Okay. Now, if this person has a third, and they have a blown pupil, what are you going to think this is? Acute, painful, pupil-involved third. You're going to think it's the aneurysm. So I tell the resident, hey, was there an RAPD? And they say this, Dr. Lee, the pupil was fixed and dilated. Can you tell if someone still has an RAPD with a fixed and dilated pupil on one side only?
Subjective.
Yes. How would you tell that?
The other one.
The other pupil. So I got a fixed and dilated pupil on the right because I got a pupil involved third. The pupil is 8 millimeters fixed and dilated, but this pupil is normal. So I can check for an RAPD as long as I have two eyes, even if I only have one working pupil. So I swing the light. I start with the right eye, which is fixed and dilated. What happens when I shine the light in the right eye? This is a fixed and dilated third nerve palsy, efferent damage. Nothing. But what's happening to the normal eye when I shine the light in the, it'll constrict. Okay, now I swing the light from the right to the left. What will happen when I swing the light from the left back to the right in the left eye if there's an RAPD? And that thing's called a reverse RAPD. That thing happens every single time you do an RAPD. You just never looked over there. So which pupil dilates in an RAPD? The correct answer, both pupils dilate. So when I swing the light from the left to the right, if there's a right RAPD, the right pupil should dilate, but so should the left. But when you have a pupil-involved third nerve palsy, you can't use the right eye because it's fixed and dilated, and you have to use the other eye. What's the name of that testing? So the resident comes out. I said, hey, did this guy have an RAPD? They're like, Dr. Lee, the pupil is fixed and dilated. Like, not that pupil, you dummy. The other one. What if there's a reverse RAPD? Then that's not the aneurysm anymore. That puts the lesion from the posterior communicating artery right into the orbital apex. And that is mucor. What will happen if my resident thinks it's pupil-involved third nerve palsy causing acute painful? What's the imaging study, did I tell you? CT non-contrast of the head. And then CT angiogram, it'll be negative. Then they do an MRI, it's red as air. And now they're about to discharge this person with a diabetic third. Maybe they did an angiogram. What would be the angiogram finding in a mucor? Normal. So now they got a CT, a CTA, an MRI, and a catheter angiogram, all negative, in a diabetic who has a pupil-involved third. And what will be the discharge diagnosis? Diabetic third. You killed them. If you had just swung that light and found the reverse RAPD, you wouldn't have done the CT, CTA, the MRI, MRA, and the catheter angiogram. And how about radiology? When they'll read this CT as there is incidental maxillary sinusitis, because that scan was not of the orbit. It was only of their head, because you told them to do a non-contrast CT of the head to look for subarachnoid hemorrhage. It'll say this: CT, non-contrast head. Impression, no acute intracranial hemorrhage. There's also incidental pansinusitis, or there's incidental sinusitis in the maxillary and ethmoid sinus. Clinical radiologic correlation required. Isn't that what they're going to say? You ordered the wrong scan because you didn't do your job, because you didn't swing that flashlight. So if you add in RAPD to pupil-involved third, where's the lesion now?
Orbit.
Orbit. What if you didn't image the orbit? You're the villain. Yes? So, yes.
Can we just clarify for the RAPD, so it will tell us that the lesion is anterior to the geniculate nucleus?
That's correct. It doesn't actually tell you it's in the orbit, but the combination of the third nerve palsy, the proptosis, and the RAPD absolutely localizes this lesion to the orbit. You have to do the Hertel on this person to find that proptosis. You have to swing the light and look at the eye that's completely uninvolved to find the reverse RAPD. Because when you walk into this room, you're going to get so excited to see the lid is completely down. You're going to lift the lid up. It's going to be a blown pupil, and the eye's going to be down and out like this. And you're going to say, oh, I know what this is. This is the aneurysm. Dr. Lee said, pupil involved, acute, painful. I'm going to be the hero of this case. I'm going to save this guy from the life-threatening ruptured aneurysm. I am God. But you're not. You're the devil. Yes? Because you didn't swing that light. And you didn't do the Hertel. Because you got so excited to see. So why wouldn't the resident do the Hertel? I'm like, Hey, did you do the Hertel? Dr. Lee, the eye is out like this. How come we do the Hertel? The corneal reflex is way over here. Isn't that what they're going to say to me? Don't do that. Don't do that. Yes? Don't do that. This is mucor. Okay, this needs a biopsy. Yes? And come back non-septate hyphae. Now you are the hero of this case. You understand what I've said? Because the newer antifungals, posaconazole, amphotericin, liposomal, save people. In the book, it says to look out for this black eschar thing. Do not wait for that black eschar thing. By the time that black eschar thing comes, game over. They're dead. So, you need to know T1, post-contrast, MR, head and orbit, gadolinium fat suppression for any optic neuropathy, but especially optic neuritis. You need to have a SELA sequence, and you need to know the difference between a snowman and a snowball, a dirty snowball, a ball of white fire and an aneurysm, a snail with enhancement, homogeneous enhancement, and infiltration of the infundibular stalk dysgerminoma. You need to know you need an A to find an A. And that A is arterial dissection, arterial aneurysm, arterial venous fistula. If your differential includes any of those A's, you need an A to find that A. There is no A in MRI. You need to have a Horner protocol. CT, non-contrast, CT, CTA, head and neck. How far are we going down? T2 in the chest. And if it's negative, you need to follow that with an MRI, MRA of the exact same area because the CT's faster and will show the dissection faster, but you still need an MRI. And the name of that sign, where there's hyperintense signal around the flow void, what's the name of that sign? The crescent sign, and that occurs in their neck, not in their head, in their neck. You need to do orbit and sinus in patients who have diabetes, DKA. You need to do a Hertel ophthalmometer, and you need to do a reverse RAPD in any pupil involved in their palsy, because that pupil, if you have RAPD, that moves the lesion into the orbit. Yes, it's in front of the geniculate, but the combination of optic neuropathy, RAPD, and third nerve is orbit until proven otherwise. And that means it's mucor. We don't have time to be doing angiograms on a mucor patient. Don't be doing no angiograms. One person can make a difference. Everybody should try. It's your job. You wrote this in your personal statement. You should be the doctor your mom thinks you are. Every day, every patient. Be that doctor. Yes? There's a reason you went to medical school. And that reason was not to do refractive surgery. All right, you guys have all that? Okay. Next one? Okay, thank you. All right, we're gonna switch gears a little bit here. The last talk that I'm gonna give you at the end, we're gonna end at 1:30, is completely different. But these are all just to remind you stuff. So optic neuritis. You need to know that the book version of optic neuritis, the one I told you, the 20-year-old white female, acute unilateral vision loss, RAPD normal fundus, doctor sees nothing, patient sees nothing, it's retrobulbar optic neuritis, MS, all that stuff, you need to know all that. That's the good part. The bad part is you need to know about these two antibodies, and the two antibodies are aquaporin 4, which is for NMOSD, neuromyelitis optica spectrum disorder, and MOG, myelin oligodendrocytic glycoprotein, antibody mediated. So there's a good version of optic neuritis. The good version, it just gets better. You give it steroids, they get better faster. You don't give it steroids, it's still going to get better. You got to scan them. MS, half the cases are idiopathic, but there's also this bad and this ugly version. The bad is called MOG, myelin oligodendrocytic glycoprotein, and the ugly is called NMOSD, neuromyelitis optica spectrum disorder. We used to call this DIVIC. It used to be called the Asian form of optic neuritis. We don't call it any of that anymore. NMOSD is a separate disorder. MOGAD, myelin oligodendrocytic glycoprotein associated disease, separate disorder. So this morning we were driving on the highway with the bad traffic. I saw all these ads for Koreatown. That means you got to be worried about Asian MS here. That Asian MS is actually NMOSD. That's me in 1978. These are my classmates. We're all the same grade. This guy and me are the same height now, but not in 1978. That's our teacher, Mr. Dorr. He's not in my class. You see that guy? This little guy told this guy, I want to be a doctor. My second choice is Jedi Knight. I try and be the mentor that that guy was for me. Because this guy is so short. Yes? That guy cannot drive. Not because he doesn't know how to drive. He cannot reach. I cannot reach the pedals. I sat on phone books, but I still couldn't reach the pedals, even if I put the seat all the way forward. So if you're thinking about starting your kid off in school earlier, you remember this book. My mom thought it was the greatest thing to start me in school and skip some grades. That was not a good idea. Because you fail to account for this. It doesn't matter if you can do the work. Yes? Still got to drive. So I did not skip my kids. Yes? They just went to school like everybody else. Oh, by the way, you should tell your mentor. This guy never told this guy how important he was to him. And that guy, Mr. Dorr, my teacher, he died of a myocardial infarction on the class field trip. He had the Widowmaker, 100% occlusion of the left anterior descendant, the Widowmaker. I never get to tell the guy thank you. So, all y'all, you better say thank you to the people. Someone sitting up here, okay? Yes, you look at your pass rate for your board. You see how much money and time it's taking to bring these people like me to come over here. You know why I did it? For her and you. You understand? Tomorrow, I wake up at 5 a.m. in the morning. 17 hours back, 10,000 miles. And then the next day, I will go to Orlando for the American Academy of Ophthalmology. Jet lag. But it's fine. So you make it worthwhile for me, okay? Don't get paid in money. I get paid in you saving someone. You come up to me at Epomec, which I'll be at in Dubai, and you tell me you saved somebody because of what I said today. That's way more powerful than any amount of money. That's worth 10,000 miles to me. Yes? Save somebody. So I wanted to help people. I wanted to have a superpower, and I wanted to work for NASA. At the end, I'll tell you what we do with NASA. Okay? Turns out superpowers are real. You have been given a great gift. That gift is the ability to detect disease and death just by looking in people's eyes. That's amazing. You can see optic atrophy from a tumor that's in their head. You can see band atrophy and say you have a tract lesion with no MR. Just you looking. Isn't that a superpower? It's a real Jedi superpower. Every day in clinic, you are trying to defeat the Grim Reaper. Yes? But with this great power comes great responsibility. You're a doctor first, an ophthalmologist second, and a vitreoretinal surgeon third. All right, we're going to talk about optic neuritis now. You need to test for 2 antibodies in every patient with optic neuritis. Their names are MOG, myelin oligodendrocytic glycoprotein, and aquaporin 4, which is NMO. Because optic neuritis is just going to get better. But if it's MOG, you have to have steroids. And they might need immunosuppression or plasma exchange. And if it's NMO, they definitely have it because N and M and an O, the M is bad. M is myelitis. It'll paralyze them. So the only person that is going to test this person at time 0 is the person that sees the optic neuritis. That's you. There is no myelitis yet. And I told you my dad would say, if it quacks like a duck and flies like a duck, then it's a duck. This is what a duck looks like. 20-year-old, white female, acute unilateral vision loss, RAPD, pain with eye movement, normal fundus, and it just gets better. You give IV steroids, you get better quicker, but it just gets better. Quack, 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 duck. What are you looking for in the MR? Multifocal white matter lesions for multiple sclerosis. Now, I told you I've been to Kuwait 4 times. When I first came to Kuwait, supposedly you didn't have any MS. That was a decade ago. Now all of a sudden you have it. I don't think that's a coincidence. I think you really had it the whole time. You just didn't know you had it. Plus, look at the change in your demographics. And after your war, look how much more MS you have now. That's weird. We really don't know what causes MS. Yeah. But when a whole bunch of people from MS land come to kick out your invaders, they brought it with them. Yes? And now it's in your country. Okay? MS is here to stay. You have MS. You probably had MS. But when I first came here, they're like, why do you want to talk about that? We don't have that. But you do have it, okay? So when the MR is done, you're going to be looking, oh, by the way, which is this, T1 or T2? It's T2, okay? You see the white matter is great. The CSF is dark, though, because this is a special sequence to suppress that fluid. What's the name of that suppression? This is flare. You can see how much better we see the white matter lesions. So you need flare for MS. You need FATSAT and enhancement for optic neuritis. And in the past, we would just say, look, your MRI is good. Good news, you don't have MS. But that's bad news too, because your MRI was normal. So if the MR shows multifocal white matter lesions, that is your grandfather's optic neuritis. Okay, that's the regular version of MS optic neuritis. Multifocal white matter lesions, MS, optic neuritis, everything you learned about optic neuritis, that's true. So here's what guys like me told you 10 years ago when I came in. If you give IV steroids, this purple thing, you get better faster. But it doesn't matter whether you receive methylprednisolone, placebo, or prednisone, everybody's going to get better. This is just the regular optic neuritis, the good version of optic neuritis. It's good because look how good the outcome is. And if you look at acuity, it's the exact same thing. Both the acuity and the field, everybody's going to get better. You just get better faster if you give IV steroids. One of the bad things that you need to know about is do not give oral steroids in conventional dosing to optic neuritis. So if you give 60 of prednisone to optic neuritis, this is intravenous, this is placebo. If you gave oral prednisone, your probability of recurrent optic neuritis is higher. That means you would have been better off if you went nowhere than if you had gone to the doctor. If you went nowhere, you got better. But if you went to the doctor and they gave you this oral prednisone, not only did it not help you, you got a recurrence. So don't poke the bear, okay? There is no role for oral steroids in conventional dosing for optic neuritis. If you give oral steroid in conventional dosing, you're the villain. You made the person get a recurrence. It would have been better if you gave them a Snickers bar. The candy bar would have been better than giving the prednisone.
What about oral steroids after IV?
Oral steroids after is fine. In fact, you do have to do that. Okay. The reason you have to do that is if you're MOG or NMO, it'll recur. So you have to give it. Okay. All right. See the fat? It's very bright. Is that T1 or T2? T1 is fat, T1 bright. Yes? I suppress the fat with the fat suppression stir, the short taw inversion recovery. See that little bit of enhancement right there in the orbit? That's the normal thing you see in the good version of optic neuritis. Good. See that? No fat suppression. No fat suppression. Gadolinium, a little bit of enhancement. If you didn't suppress that fat, there's no way you would see that little white thing right there. Just no way. The reason you need to know that is this is the total number of people who have enhancement after optic neuritis and how much enhancement you have. See, this is zero enhancement. That's only 5% of the cases. So if you do an MR of the head and orbit with gadolinium and fat suppression and it comes back no enhancement, you should be rethinking the diagnosis. Okay? That means something's not right. But if it's a lot of enhancement, you should also be thinking that's the wrong diagnosis. So we should not be really having more than 4 centimeters of enhancement. Once you start getting more than half the nerve enhancing, that's NMOSD. If it's the sheath, that's MOG. So you need to know the 2 enhancement patterns on the MR, head, orbit, gadolinium, fat suppression that would say this is not quacking like a duck. The first is no enhancement. That's bad. That means you have to do OCT of the macula and make sure it's not central serous retinopathy or macular edema or 10 million retina things that it could be that just look like retrobulbar optic neuritis, but it's not. So you need to know what a duck looks like before you can say it's not a duck. How about if they're one of your foreign workers or they're from Brazil or they have fever? Well, then you should be thinking that's not a duck. A large segment of your workforce comes from endemic areas for diseases that you have to test for. So I heard yesterday that you just get syphilis all over the place. Yes? Syphilis. I heard you have you had a methanol outbreak in a country that has no alcohol. That's counterintuitive. Why? Because they're making their own. Yes? Just because your culture doesn't accept some things doesn't mean their culture doesn't. Yes? So you have all these people you got to worry about chikungunya and HIV and syphilis and methanol and dengue fever. So as soon as you add in, where are you from? Bangladesh, India, China, Brazil. You have to think about their diseases. You understand? And even in a country that has no ethanol, you have to think about methanol. And what that means is you don't have the antidote here. So it's dialysis, that's what you get, or you die. How many of those people died? A lot, right? Die. In the US, we have fomepizole. It'll just block it.
I think only loading dose, not have maintenance.
You don't have enough fomepizole to go around.
We give them just the loading and then
It's terrible. All right, so what are we looking for? A bilateral enhancement. You see this bilateral? That duck is not quacking right. Yes? So as soon as you say bilateral, that's NMOSD or MOG. And because this is at the junction of the optic nerve and chiasm, you might get 2 types of junctional field defect. One is the regular junctional scotoma, and the other one is called junctional scotoma.
If it's bilateral, we consider infectious too.
Totally, you should be thinking every mimic of optic neuritis and MS, especially in those people who are from endemic areas of this planet. You should be ordering syphilis serology and HIV, and if they have fever, that's all the fevers, dengue and all those. If the nerve is enlarged, that also not quacking right. So optic neuritis, the good version, short segment of intraorbital enhancement. Short. But if it's big, there's something in that nerve. Sarcoidosis, IgG4, something's in there. Okay. And this one, see the enhancement is going out into the fat. You see how the enhancement is like spreading out? This one's MOG. So that could be sarcoidosis, that could be lymphoma, all sorts of bad things, but this one is the prototype for MOG. Myelin oligodendrocytic glycoprotein associated disease. You cannot let radiology just read these all as optic neuritis, because there's all these different flavors. Yes? So I need to know unilateral or bilateral. I need to know how much segment of enhancement, and is it in the sheath or the fat? Do not let them read it as impression optic neuritis. It's also bilateral. You see that? That's not quacking right either. So if it's anything other than acute, unilateral, loss of vision, RAPD, white person, young female, normal fundus, short enhancement, you should be thinking not a duct. You understand when you're supposed to be thinking not a duct? See how that nerve is, the white stuff is going outside of the nerve. You see it? It's like little tendrils. See this white thing? No bueno. Okay? No good. So, in the past, the good version, optic neuritis gets better, but you need to know that you're looking for white matter lesions for MS, but if there is no MS, that's also bad. So it's bad to have MS, but there are things worse than MS. Believe it or not, there are things worse than MS. All right, so let's see what this duck is quacking like. It's 60 years old, and they're not white, or they're me. A 62-year-old Asian male presents with acute vision loss. But instead of it being unilateral, it's bilateral. Don't you think you should be thinking about the DVIC, the Asian form of MS and me, NMOSD? So as soon as you walk in and it's me, you better be ordering the lab on me. Don't be telling me I have optic neuritis and MS and good news, Dr. Lee, your MRI doesn't show any MS lesions and we can give you IV steroids, you'll get better faster. Don't be telling me any of that. If it's bilateral, there might not be an RAPD. Severe pain with eye movement. You got to be thinking about apoplexy and ophthalmic aneurysm. Remember that? Ball of fire person. The disc is swollen. That's not good. Okay? It doesn't get better. All these are bad. Not quacking right. So of course you need to know about what a duck walks like, quacks like, and swims like. That's not a duck. That's not a duck. Okay. So these two are antibodies. Okay, antibodies. MOG, myelin oligodendrocytic glycoprotein. Aquaporin 4, which is NMOSD. They both are B cell to plasma cell to antibody. One's called anti-MOG, the other is called anti-AQP4, that's NMOSD. The targets are different. They both cross blood-brain barrier into central nervous system. MOG attacks the oligodendrocyte and the myelin. But AQP4 attacks the aquaporin water channel on the astrocyte, and the astrocyte will die. And if astrocyte dies, game over. No visual recovery. And if it's in your spine, you're paralyzed. So NMO, you should be thinking about NMO if I'm sitting there, or if one of your Asian cohorts are in there, or African cohorts in there. So as soon as it's not a white person, you should be thinking, could this be NMOSD? The Asian form, DeVick syndrome, is NMOSD. And almost all are misdiagnosed as a duck, multiple sclerosis. So this is a map of MS. Remember the latitude thing? Canada, North America, Europe, Russia. In the southern hemisphere, New Zealand, Australia, nothing in Africa except South Africa, and that is Uruguay, and Buenos Aires, Argentina. The same places where the wine is. New Zealand Sauvignon Blanc, Australian Shiraz, South African Chenin Blanc, Argentinian Malbec. Napa Valley, Burgundy. You understand? If you walk into that room and you say, "Well, you're a country that doesn't make any NMOSD." We know that because this is the world map showing the prevalence of NMOSD. So the NMOSD, you have to think about it even in people from here, but this zone right here. And guess who lives in that zone? You. Yes? Your GCC rates are higher. Yes? Not just because of your expat population, but because your risk is different. In the USA, the risk of NMOSD is 11 per 100,000. And if you're Afro-Caribbean, similar number. This one's the MOG. Remember the sheath enhancement? MOG, myelin oligodendrocytic glycoprotein. So you need to know that if it's outside of the nerve and in the sheath, that's the one that's MOG. MOG is bad, but it's not ugly like NMOSD. It's more aggressive. It's not as bad as NMO, but it's worse than MS. The ugly one is called NMOSD, neuromyelitis optica spectrum disorder. It's optic neuritis. It's often bilateral, simultaneous or sequential, and the thing we're worried about is myelitis, transverse myelitis. So if we have three contiguous segments, three contiguous vertebral segments, that's longitudinally extensive. And you have to order the test, NMO-IgG for aquaporin 4. It doesn't recover. It's bilateral. The brain MRI is normal. The LP might show CSF pleocytosis more than 50. All those are atypical, not quacking. This is MR, T1, orbit, fat suppression. Too long of enhancement. You see that? Bilateral. It's supposed to be short segment intraorbital. So short segment intraorbital, that is your father's optic neuritis. That is multiple sclerosis. But this bilateral and longitudinally extensive in the optic nerve means more than half the nerve is enhanced. See the chi, the X, the whole thing is enhancing. See that there? And in the spine, longitudinally extensive is defined as more than 3 contiguous segments. So if we have longitudinally extensive enhancement in the nerve or in the spine, NMOSD. Million different patterns. And now you know that you got to know that tract one. Because acute bilateral homonymous hemianopsia, RAPD, band atrophy, that's also NMOSD. Yes? Bilateral NMOSD, chiasmal NMOSD, junctional scotoma, all of them. You have to order the aquaporin 4. So if you just took a pencil and you drew from the hypothalamus and the chiasm all the way around subependyma down to your spine, you're passing by this floor of the fourth ventricle here, that's area postrema. And that means you need to ask some super weird questions that you never asked optic neuritis patients ever before. The super weird questions are intractable hiccups, unexplained nausea and vomiting. That means you got to go dig around in their chart because a month ago or 2 months ago, they saw GI. And GI saw them because they had nausea and vomiting. GI scoped them, EGD, and colonoscopy, found no structural lesion, discharged the person. That's aquaporin 4, NMOSD, area postrema syndrome. Same for intractable hiccups. In hypothalamus, that's symptomatic narcolepsy. And if it's in your brainstem, it's diplopia and nystagmus. In your spine, and weakness, numbness, tingling, loss of bowel or bladder. Transverse myelitis is what you're looking for. Because if you don't make the diagnosis, they're going to go blind and be paralyzed. We don't want to find this longitudinally extensive enhancement. Of course, person has transverse myelitis, everyone knows that's NMO. The one you don't know is the N and the O, no M. Do not wait for the M. Just like don't wait for that black S card thing. You have to order the test. So in the NMOSD criteria, if you have one core criteria, an N and an O, optic neuritis, plus the lab, then you have it. That means you can have NMO, no M. If you only have M and you have the antibody, aquaporin 4, you have it. No NO, just M. And weirdly, you can just have APS, area postrema syndrome. That means you have APS and the antibody, you have it. No N, no M, no O. You have NMO with no N, no M, no O. You only had area postrema. Do you understand how powerful this lab test is? A single core criteria and the blood test makes the diagnosis. What if you don't order it? You're the villain. You have to order the test before we give the steroid. Because if we give the steroid, what will happen to my antibody test? It will go negative. And what we're trying to prevent is this super horrible thing, which is astrocyte death. And if that astrocyte death occurs here in your spine, you won't get up out of that wheelchair, ever. We're trying to prevent paralysis here, myelitis. By the time the N, the M, and the O all occur together, everybody knows that's an MO. You should be thinking about it in anybody who didn't recover. Bilateral, either simultaneous or sequential. If it's recurrent and there are no MS lesions, if you have atypical MS, all of these are not quacking right. Or if you have greater than 50 white cells in the CSF. And of course, if you have transverse myelitis. So you should be ordering aquaporin 4 in anybody who has a long spine lesion, multiple episodes of optic neuritis, but probably single episode optic neuritis and even short lesions all probably need aquaporin 4 and MOG. They just come together. Okay, you have to just do both. NMO, SD, and MOG. They just together. So look at this right here. This is the cumulative rate times 0 of developing that right there, transverse myelitis. You see that little blue thing? The only person seeing this patient right here is you. If you don't make the diagnosis within 10 months, 30% of the people have already had transverse myelitis. You understand how dangerous this is? This is another optic neuritis event. Within 2 years, it's just going to happen again. And that's going to blind them. So don't do this. Yes?
So in this chart, they showing that they present with myelitis first.
These people right here came with optic neuritis.
Oh, okay.
Then they got transverse myelitis, or they got recurrent optic neuritis.
Because we are usually getting MRI brain orbits. Is there situations where you would order? Because we send the workup all at once. Will you order
Good job.
spine as well?
If the MR of the brain shows no white matter lesions, yes. If it's bilateral enhancement, yes. If it's longitudinal enhancement of the optic nerve, yes. If it's atypical in any way, old person, not white person, brown person, African, Asian, yes. See that NMO seronegative versus the red one, which is seropositive. If you're seropositive at time 0 from first optic neuritis attack, this is you. You are here. Look what's going to happen to this person. Half the people are going to get paralyzed. Half. There's no M yet at time 0. The only person touching this chart is you. The myelitis, it's coming. You see? We know what this looks like if you don't treat it. They're going to get paralyzed. Look. Almost everybody's paralyzed. Almost everybody is paralyzed if we don't do something about this. 10% of the people are going to die. 40% of the people have been misdiagnosed. Average duration to time to treatment, 3.3 years of no diagnosis.
You should do all the lab
Everything. The only person you don't have to order it for if their head is full of flare, white matter lesions for MS. That one you don't need it. That is your father's optic neuritis. That's the regular version. Everybody else gets both AQP4 and MOG. Everybody else. So if it quacks like a duck and looks like a duck and flies like a duck and it's full of duck MRI white matter lesions for MS, that one you don't have to test. Everybody else you do. What if you said, I can't remember that, I just test everybody? It's fine. Because the false negative and false positive rate on the test is so low. No one will come and get you. No one. So you need to test for both NMO, which is AQP4, and MOG, because it could be good. That's the regular optic neuritis, the thing I came and talked to you about 10 years ago. It could be bad. That's MOG. That's in the sheet. That needs IV steroids. Could be ugly. That's paralysis. Death. Don't read. I told you that that guy right there wanted to be a doctor, but his second choice, Jedi Knight. It turns out I get to be both. Don't you want to be both? I want you to be both. Your next patient, I will be there with you. The Force will be with you. If you can't remember the stuff I'm telling you, just come visit me on YouTube. I'll be there with you. You can just literally watch it on YouTube. I didn't actually have to come here. Half of you have already seen me on YouTube, right? Maybe more. But I'm here and it's making a difference in a different way. Watching it on YouTube is not quite the same, is it? As me standing here in front of you. It will affect you in ways that you can't possibly imagine. I know this because that guy affected this guy in ways that this guy can't possibly imagine. This is my best friend in high school. This is my second best friend in high school. This is this guy's brother. We still keep in touch to this day. You need to know about optic neuritis, the good, the bad, and the ugly. Do you have any questions about this section here on optic neuritis? All right, I'm going to let you guys take a 10-minute break. And we'll come back. 10 minutes. 10-minute break.